Welcome to Stancost's 30-day pass guarantee crash course. If you're preparing for the NCLEX and feeling overwhelmed, you're in the right place. This 30-day mini crash course is designed to help you focus on the most important NCLEX topics and questions so you can boost your confidence and maximize your chances of passing. By watching all episodes of this course, you'll gain the knowledge and test-taking skills you need to succeed. We've carefully selected high-yield topics that the NCLEX loves to test again and again. Each episode is structured to give you a clear, in-depth explanation of key concepts so you truly understand the material. A dedicated NCLEX-style question session at the end, packed with high-yield questions that are likely to appear on your exam. But if you're looking for a full, structured study plan that guarantees success, then this is just the beginning. You can enroll in our full-length NCLEX crash course. For the past 3 years, more than 10,000 students have successfully passed the NCLEX using this program. This isn't just another review course. It's built from real insights gathered from 5,000 registered nurses who have passed the NCLEX. We know exactly what it takes to succeed, and we've designed this course to give you everything you need to pass on your first attempt. Here's what you'll get inside. 300 plus hours of recorded video lectures covering all essential NCLEX topics in detail. 100 plus animated crash course lessons, making even complex topics easy to understand. 500 next-generation NCLEX NGN questions so you can master the new exam format. 10,000 previously asked NCLEX practice questions, reinforcing your learning with real exam-level difficulty. 30 full-length practice tests, helping you develop strong test-taking strategies. A comprehensive NCLEX ebook for in-depth review and quick reference. 1 year unlimited access, so you can study at your own pace without stress. This is your chance. Enrollment is open for a short time, and right now you can get in for 70% off. Enroll now and take control of your NCLEX prep. Visit website www.stancoastnclexcoaching.com. Link also in the description box. Now, let's dive into today's session and get started.
Welcome, everyone. Today, we'll discuss the administration of parenteral nutrition, which is a life-saving intervention for patients who cannot receive nutrition via the gastrointestinal tract. And so we'll explore its indications, types, administration, and key nursing considerations. Importantly, stay with us until the end of this video to complete a set of NCLEX-RN questions. Now, we'll start with a question: what is parenteral nutrition? Well, it is an intravenous method of providing nutrients when oral or enteral feeding is not an option, and it supports patients with severe gastrointestinal dysfunction, could be malnutrition, or those requiring bowel rest. And the nutrition is categorized into peripheral nutrition, or we have the Total Parenteral Nutrition, or the TPN. Now, I want to emphasize here that parenteral nutrition is categorized based on the route of administration, the nutrient concentration, the duration of use, and the risk of infection. So let's talk about the route of administration. Now, the nutrition here in the PPN is administered via a peripheral intravenous IV line, typically inserted into a smaller vein or maybe the veins of the arm. And this is used when only partial nutritional support is needed, because we know that peripheral veins cannot tolerate highly concentrated solutions or really high percentage of dextrose. Now, for TPN, this is going to require a central line, such as a central venous catheter, or maybe a peripherally inserted central catheter. This is what we refer to as PICC line. Now, when we are talking about the central veins, this could mean the subclavian or maybe the internal jaw causing vein irritation. Now, according to the nutrient concentration, with the PPN, the nutrition here contains lower concentration, particularly with dextrose. That's going to be less than 10%. There's also amino acids and lipids. And there is going to be limited osmolarity threshold. And that's why it's only going to accommodate about less than 600 milliosmoles per liter to prevent phlebitis. Now for the TPN, since it's going to allow delivery of higher concentrations, and so we're talking about 15 to 25% of dextrose here. And it also includes amino acids, electrolytes, there's also vitamins, maybe trace elements, and lipids. We have the lipid emulsions. Now, since this is going to provide full nutritional support, particularly with a severe malnutrition, or maybe those who cannot tolerate enteral nutrition, and so there's really a need to maintain the nutrition using those larger central veins. Now, according to the duration of use, well, this is going to be short-term for the PPN. Okay, so we're talking about less than 2 weeks of the parenteral nutrition. And this is commonly used post-op for those patients who may have mild to moderate malnutrition, or when enteral feeding is temporarily inadequate. How about in TPN? Well, it is also intended for long-term use, maybe weeks of parenteral nutrition, or maybe months or even longer. And this could be used for those patients that may have a short bowel syndrome, or could be prolonged bowel obstruction, or there is severe malabsorption disorders, or maybe chronic gastrointestinal dysfunction. Now, if we're going to ask, what about the risk of infection? Well, for the PPN, there's lower risk of infection because the catheter is placed in a peripheral vein, reducing the likelihood of bloodstream infections. However, frequent IV site changes are needed due to the risk of thrombophlebitis, and possibly it could be every 2 days of changing the peripheral IV. Yes, that's how frequent it can be. What about the TPN? Well, there's a lot higher risk of infection here. We know that central venous access can create a direct route for the bacteria to enter the bloodstream, and so it increases the risk of CLABSI. That's the central line associated bloodstream infections. And so this is going to require strict aseptic technique, catheter site care, and also routine monitoring for the signs of infection. Now let's talk about the nutritional components in the parenteral nutrition and their mechanism of action. Now, the parenteral nutrition can deliver these nutrients directly to the bloodstream, and they also bypass the digestive system. And also it includes the carbohydrates, mainly dextrose, and this is going to give the client primary energy source to help meet the metabolic demands. And it's because total parenteral nutrition solutions contain high glucose concentrations. They are hypertonic. They require central venous administration to prevent thrombophlebitis. And also there's going to be proteins. We are talking about amino acids here, which are very critical for tissue repair and preventing muscle breakdown. There's also delivery of the lipid emulsions or fats, which will provide concentrated calories and essential fatty acids. And we also have the electrolytes, vitamins, minerals to maintain fluid balance and to also maintain metabolic functions and prevent deficiencies. Now, these components will work together to sustain the client who cannot receive adequate nutrition through the GI tract. Now, what are the uses for the parenteral nutrition? Well, this is used when the patient's body is not able to get enough nutrients through the regular eating or tube feeding, and this can happen for several reasons. And some patients who have GI dysfunctions like bowel obstruction, or maybe severe malabsorption or Crohn's disease, this is going to make them hard for their digestive system to absorb nutrients properly. Others may be having the dysphagia. They will be unable to eat. And also maybe for those who are recovering from major surgery or dealing with other issues in the GI tract. Now, this PN, or the parenteral nutrition, is also indicated with severe malnutrition for those maybe having those extensive burns, for those having chemotherapy, or those patients with cancer or AIDS. They're going to need extra nutritional support. Now, let's talk about the administration routes this time. And so parenteral nutrition can be given in two ways depending on how long a patient needs it and how concentrated the solution is. And so first here, it can be administered through as a peripheral nutrition, right? So again, this is used for short-term support. It is delivered through the large veins in the arm, like with a midline catheter or an ordinary peripheral access, and it has a lower content in dextrose to avoid irritating the smaller veins. Whereas we have the central venous access device, we are gonna use the TPN here, and this is intended for long-term use, and this is gonna require the central access. We're talking about the PICC line or the central venous catheter. And again, the solution here is hypertonic, which is not going to be advisable to be given in the peripheral veins. Now, nursing tip for you here, if when the TPN is suddenly unavailable, we're going to administer the 10% dextrose in water, or D10, as prescribed by the provider to prevent hypoglycemia, since we know that the TPN contains a high amount of glucose. And so stopping it abruptly can cause that dangerous drop in the glucose. Now, we will include the discussion about the lipid emulsions and other components in the solutions. And for the lipid emulsions, these are very important part of the nutrition because they provide essential fatty acids and also extra calories. And without these fats, patient could develop fatty acid deficiency, which can lead to skin issues, weakened immunity, and also poor wound healing. Now, the sources of the lipid emulsions, they're actually made from soybean, safflower oil, and adding egg yolk as the emulsifier to keep the fats evenly distributed. And the lipid emulsions are administered through a central line, or it could be a peripheral line. And what you're going to need to do here is to make sure to check for the separation of the emulsion before use, right? And so if you see large fat globules or maybe yellowish layer on top, you need to discard the lipid emulsion because it's not safe. Now, there's also some rules when you are administering TPN or administering the lipid emulsion. You're going to need to use this filter. That is our 1.2 micron filter, and this is going to be applicable when you are administering the lipid emulsion. And the reason for that is to trap large fat globules and to prevent the risk of fat embolism. Whereas when you are going to administer the regular TPN solution, dextrose, we are going to use the 0.2 micron filter. And this is to prevent or to help remove bacteria, remove tiny particles, and also to prevent infections, keeping the solution sterile longer. And so this is our 0.2 micron filter on the right side of the screen. Now, there are also additional components in the peripheral nutrition. So there's going to be vitamins and minerals to address some deficiencies. Possibly there's going to be incorporation of the insulin, particularly regular insulin, since the nutrition is rich in glucose. And so this is added to prevent hyperglycemia. And in some cases, heparin will also be added, and this is to prevent clots from forming inside the catheter to ensure smooth infusion. Now, this is a tip for you. When you're going to be asking the NCLEX, specifically with the administration type of question, you always need to double check the compatibility before adding any medications to the parenteral nutrition to avoid any precipitations or any drug interactions. And to be safe, you need to administer the other IV medications into a different port in the central line, okay? You don't really want to mess with the dedicated port for the TPN. Now, how is the parenteral nutrition administered? Well, there are two main ways that we can deliver this nutrition. There's that continuous and also cyclic infusion. Now, for the continuous infusion, think of this as a round-the-clock nutrition, and this is commonly used for hospitalized patients who require consistent nutrient delivery because of severe malnutrition or critical illness. And this is going to keep the blood sugar level stable, but a constant infusion of glucose increases the risk of hyperglycemia. So there's a need for frequent glucose monitoring, and we're talking about every 4 to 6 hours as ordered. The other one is the cyclic type of delivery, and this is usually administered 8 to 12 hours overnight, and this is more like a nighttime feeding. The patient gets the PN or the parenteral nutrition overnight. So not really feeding orally, but it's similar to that. It's going to be administered overnight. And this is going to be ideal for those patients who are transitioning to the oral or enteral nutrition, or we're talking about tube feeding, because it encourages normal eating habits while still providing nutritional support. And this is also beneficial for those patients who don't want to be tied to an IV pump all day. So this improves their mobility and their quality of life, especially for those on long-term home parenteral nutrition. However, there is a drawback with the cyclic type of delivery. There's going to be blood sugar fluctuations, and so glucose monitoring here remains very critical. Now, when you are going to ask, how is this TPN or parenteral nutrition's going to be safely discontinued? Yes. Well, you just cannot stop the parenteral nutrition suddenly. It has to be done gradually, and this is to prevent dangerous blood sugar crashes. And what we're going to need to do here is to taper. That is the clue there. We're going to have to taper down the infusion because we know that the nutrition contains high percentage of glucose, and the body gets used to this steady supply of dextrose. And so if we are going to stop it suddenly, the pancreas keeps producing insulin, but there's no glucose source anymore. So hypoglycemia can happen. And to prevent this, the parenteral nutrition has to be gradually reduced over several hours while the patient's blood sugar is being monitored. Now, we also need to monitor the client's oral intake, as we are going to really transition the patient to oral or enteral tube feeding. And as the oral intake increases and the patient can tolerate the regular food, the parenteral nutrition rate is also lowered until it can be stopped completely. Now, when you are going to be asking the NCLEX about the removal of the central line specifically, especially when you are going to be tested about a TPN, well, the central venous catheters actually carry a higher risk of infection, and so the central line should be removed as soon as they are no longer needed. Of course, you need to consult the provider about this, about how long this central line needs to stay in. Now, for patients receiving peripheral parenteral nutrition via a regular peripheral IV, the process is much simpler, and the IV can be discontinued when appropriate. Now, let's talk about some complications here about the parenteral nutrition therapy. We know that this is a very crucial intervention, but it comes with several potential complications and risks that will require you to closely monitor these things. And so one of these high complications are air embolism. That is one of those. And so again, this is something that can happen when the air sneaks into the central line, especially during the insertion of the catheter, or when you are doing the tubing changes. And we know that we are going to change the tubing every 24 hours, every time when the bag is to be changed. And so you can avoid this by making sure all connections are tight. You're going to have to use an air eliminating filter and have the patient do the Valsalva's maneuver when you're changing the tubing as well. Or when there is a need to change the catheter, you definitely need to have them do the Valsalva's maneuver. Now, hyperglycemia is another risk because of the higher concentration of the dextrose in the nutrition, it can cause spikes in the blood glucose. So you need to monitor their blood sugars at least every 4 to 6 hours or as prescribed. And also you're going to have to manage that with prescribed insulin doses. And you're going to have to adjust the TPN infusion as prescribed. Now, hypervolemia is another thing. Whenever there is going to be too much fluid from the TPN, this can lead to fluid volume overload, which may also precipitate pulmonary edema and high blood pressure. So what we're going to need to do here, we have to monitor the patient's daily weights, monitor the intake and output every 8 hours in the med-surg settings, maybe every 4 hours in other higher levels of care, and we have to adjust the infusion rate according to the order to prevent the fluid buildup, and also monitor the patient for any signs and symptoms such as shortness of breathing and crackles in the lungs. Hypoglycemia is another complication, and this is going to happen if you are stopping the infusion suddenly. This can really cause a crash in their blood sugar. So what we're going to need to do here to prevent this from happening, we're going to have to taper off the rate gradually as ordered. And if discontinuation is unavoidable, we're going to have to give 10% of dextrose IV to keep the blood sugar stable. And of course, you need an order for that as well. Another complication is the infection, and I'm talking about the CLABSI. This is because the central line is a direct entry point for the bacteria. It increases the infection risk. And so you need to follow strict aseptic technique. You need to check the insertion site regularly, change dressings as per protocol, and you also need to disinfect the ports, the hubs, before accessing the IV. Also, there is pneumothorax. This can happen if the lungs is accidentally punctured during the central line insertion. And also, in order to detect this from happening, or to make sure that we know that there is this complication, we can confirm the placement of that PICC line with a chest x-ray before starting the TPN, and also monitor for any signs of respiratory distress like difficulty breathing or reduced breath sounds. There's also refeeding syndrome, and this is going to happen if the nutrition is restarted too quickly in a malnourished patient. And so this can lead to dangerous electrolyte imbalances. There's going to be low phosphorus levels, low potassium, and also low magnesium that can happen. And so we can prevent this by starting the parenteral nutrition slowly as ordered, and also to monitor the electrolytes closely. And most of the time when the patient is on the TPN, there's going to be daily checks of the electrolytes as well, or if there is none, you're going to need to obtain that order. Now, what are the key responsibilities here for nurses in the administration of the PPN or the TPN? Well, we definitely need to verify the correct parenteral nutrition formulation before we give that solution. We also need to prevent infections. There should be no IV meds, blood draws from the parenteral nutrition line. It should have its own dedicated line. Now, there's also a need for daily change of the TPN bag and also the tubing, and this is to prevent bacterial growth and infection. Again, even though you will see that there might be a large volume that is still left in the bag, it has to be discarded, right? You don't want to keep that IV bag or solution more than 24 hours. And that is a best practice. Another thing that you need to do here is to use the appropriate filters. Like I've said earlier, you're going to use the 1.2 micron filter for the fat emulsion, and this is to prevent the large fat globules from entering the circulation, and the 0.2 micron filter for the amino acids for the dextrose solution, and this is going to help remove the bacteria and also particulate matters, and also to protect from any microbial contamination, and also extends the sterility of the solution. Now, we also need to monitor the client's glucose every 4 to 6 hours, or it depends on the provider's orders. Also monitor for their electrolytes daily to prevent complications. And we need to assess the client for the refeeding syndrome, wherein there is sudden shifting of their potassium levels, magnesium, and phosphorus. This can lead to weakness, confusion, and respiratory distress. Now, we are going to recap here real quick. Don't forget about the key considerations for the parenteral nutrition. And so when you're managing the PN, you need to keep a close eye on the patient's responses. And so again, we need to do careful monitoring. It comes with so many risks. So we're going to need to do regular laboratory checks about the electrolytes, their vital signs. Keep an eye on the temperature, because this could give you an idea that maybe the patient is having a infection in the blood circulation, and also keep that assessments to help catch those potential complications early. Also, I need you to recall the differences between the PPN and the TPN. Again, the peripheral parenteral nutrition is for short-term use, and it's delivered through the peripheral vein. And we have the TPN. This is more of a concentrated solution. It provides complete nutrition, but it requires a central venous catheter, and there's a lot of higher risk involved when central line is used. And also, we need to prevent complications to keep patients safe. You need to practice aseptic technique, and also to monitor their blood sugar levels, which can we know that with the dextrose, right? And electrolyte monitoring, again, we need to keep an eye on the daily labs to monitor for any imbalances for the sodium, the potassium, magnesium, and phosphorus levels, to prevent any cardiac dysrhythmias, right? And also some neurological issues that can arise from the electrolyte imbalances. And so we're going to have the question and answer session right now. And so we have our first question. It states, the nurse is providing care for a patient receiving TPN via a central line. What intervention should the nurse implement to minimize the chance of infection? Options: A, apply aseptic technique when changing dressings. B, monitor the patient's body temperature. C, administer IV antimicrobial medication. D, evaluate the white blood cell count. The correct answer here is letter A. Again, a central venous access device provides a direct access to the bloodstream, so it's making any contamination a serious risk for the CLABSI, right? And again, this is an open gateway for the bacteria to go inside the internal system. Now, what we're going to need to do here is to use the aseptic technique, sterile technique during dressing changes. That's the best way to prevent bacteria from entering the site. We need to, when you are doing the dressing changes, always adhere to the protocol. We want to make sure that you are masked, you have the sterile gloves, and also you have to possibly use some head bonnet here to decrease the incidence of contamination when you are doing the dressing changes. And also use the chlorhexidine or any antiseptic solutions to ensure that the dressing changes are done correctly. Now, why are the other options incorrect? Let's have letter B here. Monitor the patient's body temperature. This is important because fever is often an early sign of infection, but here's the key. It doesn't prevent infection. It only helps detect it. So going back into the question, it asked ways to eliminate, or a way or measure to minimize the chance of infection, which means prevention rather than detection. That is why letter B is incorrect. Letter C is also incorrect. Well, the routine use of prophylactic antibiotics is not recommended because it can lead to antibiotic resistance, and it can also disrupt normal flora, making the patient more vulnerable to infections later. And so antibiotics treat infections, but they don't prevent them unless a specific protocol exists. Now, we have letter D, another incorrect option. Well, a high white blood cell count is going to indicate infection, but again, this is a diagnostic tool rather than a preventive measure. Again, go back into the question. It's asking how to prevent infection, not how to monitor it. So in order for you to answer this question correctly, you need to look for the phrases minimize the chance of infection in the question stem. This tells you to focus on prevention rather than detection or treatment, since aseptic technique directly prevents bacteria from entering the bloodstream. That is the best answer. Now, quick reminder for you, when you're answering the NCLEX, you need to focus on interventions that actively prevent complications when you are asked this way, right? Not just monitor. And so if the question asks how to prevent an issue, you need to choose those actions that reduce risk rather than actions that detect problems after they occur. Let's have number 2. A nurse is caring for a malnourished patient who recently started TPN. A capillary blood glucose check is performed. Based on the following result, what action should the nurse take? So referring into the blood glucose here of 430 milligrams per dl. What is your step here? We have the options: A, contact the healthcare provider; B, discontinue the TPN infusion; C, reduce oral intake; D, slow the TPN infusion rate. The correct answer here is letter A. It's because the TPN contains high concentrations of dextrose, which means it can significantly raise the blood glucose levels. And for patients who are malnourished may have trouble regulating blood sugar because their body is not used to handling large glucose loads. And so a blood glucose of 430 milligrams per deciliter is extremely high. It puts the patient at risk for hyperosmolar hyperglycemic state. It's going to lead to dehydration and electrolyte imbalances. And so you need to immediately notify the provider so that interventions such as insulin administration or possibly an adjustment to the TPN rate can be made. Now, don't get me wrong here. Most often when you are dealing with a patient that is getting TPN, it is accompanied by a sliding scale of insulin, most oftentimes. But if in the case wherein the blood sugar becomes critically high at some point, you need to notify the medical provider to address that urgent issue. Okay, so it might require maybe an additional dose of extra insulin, right? Or maybe a decrease in the rate. Now, why are the other options incorrect, such as letter B, discontinue the TPN solution? Again, stopping the TPN abruptly is dangerous because the body adjusts to the high dextrose intake, and suddenly stopping it can lead to hypoglycemia. Instead of stopping the infusion, you should notify the medical provider. Letter C here is also incorrect, and since the patient is likely NPO while receiving TPN, reducing the oral intake would not fix the problem, because the glucose spike is coming from the TPN, not from the food intake. And besides, adjusting dietary intake is not within the nurse's scope of practice without the provider's prescription. Letter D is also incorrect. We know that slowing the rate may help, but the nurse cannot independently adjust TPN without an order from the medical provider. And so changes to the TPN infusion should be prescribed based on the clinical evaluation. And so I want you to focus into the clues in the question, such as the glucose of 430 milligrams. This should be enough to alert you that this is a critical value, right? It requires immediate intervention. And the question asks what action the nurse should take. So you need to look for an option that involves notifying the provider, because the nurses cannot adjust TPN or administer insulin independently. And so when you're going to be asked with this type of question, especially an abnormally high or maybe low laboratory value, the safest answer here is usually the one that involves notifying the provider. We are dealing with critical lab value. And this is especially true if the nurse does not have an independent action that they can take, like administering additional insulin coverage outside of the current medication prescription. Number 3, a client with a bowel obstruction is receiving total parenteral nutrition via a central venous catheter and is also scheduled for IV antibiotic therapy. What should the nurse do before administering the antibiotic? Options: A, use a different IV access point. B, pause the TPN infusion for 30 minutes. C, flush the central line with saline solution. D, determine if the TPN and antibiotic are compatible. The answer here is letter A. A dedicated central line for TPN should never be used for other medications. Again, the TPN is a highly concentrated mixture of glucose, amino acids, possibly lipids, and electrolytes. And when you are adding another drug by injecting that medication into that same port or same line, this can cause precipitation, maybe chemical incompatibility, which can block the catheter. It will render the medication ineffective. And using the same line for TPN and other medications can also increase risk of infection because you're breaking the sterile barrier, exposing the bloodstream to the pathogens. Remember that we are dealing with continuous infusion here. And so for these reasons, you need to have a separate IV access, or maybe use another port if we are dealing with maybe a 2-port central line or maybe a 3-port central line. You never mess with the dedicated line used for the TPN. Now, why is letter B incorrect? Well, we know that interrupting TPN can lead to hypoglycemia and instability in their metabolism, okay? The TPN is the only patient source of nutrition, and stopping it suddenly without any backup plan can cause some complications. Now, letter C, flushing the central line with saline. It might help clear the line, but it does not eliminate the risk of drug incompatibility. Because even after flushing, there might be some small amounts of the TPN residue that can mix with the antibiotic. It can lead to crystallization and inactivation of the drug that is delivered. Letter D is also incorrect. Even if they are technically compatible, mixing medications with TPN is still not recommended, okay? Because the high sugar content of the TPN makes the central line a prime site for bacterial growth, so it's best to avoid unnecessary line access. Now, for you to answer this question, since the patient here states, or the question here states that the patient is receiving a TPN via a central line and is scheduled for IV antibiotics, this should be a signal that this is a red flag, right? The administration of the medication into that same line should not occur, okay? Now, another strategy for you to use when you're answering this type of question, especially with TPN medication administration, assume that mixing them is unsafe unless you have clear guidance otherwise. All right, let's have number 4. A patient receiving TPN reports nausea, excessive thirst, and increased urination. What assessment should the nurse prioritize to identify the cause of these symptoms? Options: A, measure capillary blood glucose. B, check rectal temperature. C, review the most recent potassium level. D, assess blood urea, nitrogen, and creatinine levels. The answer here is letter A. The nausea that we are noticing, the patient here, hang on a sec. The option measure capillary blood glucose is, hang on a second. This is actually corresponding to the manifestations that the patient is displaying, all right? Nausea, excessive thirst, and increased urination. Now, these signs are actually hallmark symptoms of the hyperglycemia, which is a common complication of the TPN due to the high dextrose content. And when a patient receives TPN, especially if they're malnourished, their body will struggle to handle the sudden glucose load. They are going to end up with a hyperglycemia. So we need to check that capillary blood glucose. This is the quickest way to confirm if the hyperglycemia is the cause. And this is going to lead you to act on it maybe the administration of the insulin that is prescribed, or maybe adjusting the rate of the infusion as ordered. Now, what about letter B? Checking rectal temperature. Well, fever. Do we have fever in the scenario? No, we don't. Now, we know that fever indicates infection, right? But the symptoms that we are presented with, we have thirst, nausea, urination, do not really suggest an infectious process. And so hyperglycemia does not usually cause fever. Letter C is also incorrect. We know that TPN can cause electrolyte imbalances, especially hypokalemia or possibly hyperkalemia. This can lead to either muscle weakness, arrhythmias, or paralysis in hypokalemia, but not excessive thirst or urination. Now, the symptoms described are much more consistent with a glucose problem than a potassium problem. Letter D is also incorrect. The BUN and creatinine measures the kidney function, and also it can possibly detect kidney disease. But the nausea and thirst in this scenario are more consistent with the hyperglycemia. So you need to discard this option. Okay. Again, when you are going to be presented with the manifestations such as the excessive thirst, nausea, increased urination, these are classic signs of hyperglycemia. So you need to prioritize in monitoring the patient's blood glucose level. And this is talking about prioritization in your assessment. So you need to do the assessment first. All right. Let's have number 5. A patient with a central venous catheter receiving TPN suddenly develops signs of an air embolism. What nursing actions should be taken to reduce harm? Select all that apply. Options. A. Close the catheter clamp. B. Position the patient on the left side in Trendelenburg's position. C. Contact the healthcare provider. D. Inspect the IV tubing for air bubbles. E. Administer a rapid IV fluid bolus. The answers are letters A, B, and C. Again, reviewing about air embolism. This is occurring when the air enters the bloodstream through maybe a disconnected or a damaged catheter. So this can block the circulation to the vital organ. So this is a medical emergency. And why is it that we have A, B, C as the answers? Well, when you have letter A, it prevents more air from entering the bloodstream. And this is the first and most immediate action to contain the problem. Now, letter B, positioning the patient on the left side in Trendelenburg's position. This can help trap the air bubbles in the right atrium. It prevents it from reaching the lungs. It prevents it from reaching to the brain or the heart, where it could cause the stroke or maybe cardiac arrest. And the left side Trendelenburg, which is the head down position, can also help the air remain in the venous system until it can be absorbed by the body. Letter C is also correct. Contacting the medical provider is critical here because the patient who has air embolism requires immediate medical intervention. And so we're going to have to possibly anticipate some more orders to be carried out. There's going to be a need for oxygen therapy, maybe aspiration of the air bubble if there has been a large volume of air that has been introduced. So we have to expect those as well. Now, what about letter D? Inspect the IV tubing for air bubbles. Well, at this point, the embolism has already happened, and checking for air in the tubing does not resolve the problem. We have to prevent. But right now, the focus is managing the existing embolism, and that is why we have ABC. Now, what about letter E? Administer a rapid IV bolus. This could actually push the air bubble further into the circulation. So this can worsen the embolism. And again, this is not the priority intervention when the air embolism has already developed. Okay. Now, the statement here, or the phrase suddenly develops signs of air embolism. This means that you should look for immediate actions to stop the embolism from worsening. So look for the words like reduce harm. This can tell you to prevent the progression and to stabilize the patient. Number 6, A nurse is caring for a patient receiving TPN. Which intervention is most effective in reducing the chance of infection? A. Use sterile technique when handling the TPN solution and equipment. B. Verify that the prescription details match the label on the TPN solution. C. Administer preventive antibiotic therapy as a precaution. And D. Check the patient's vital signs every 4 hours. The answer here is the letter A, as we know that TPN can bypass the normal GI defenses. It actually allows direct entry into the bloodstream through a central line. And so this can significantly increase the risk of the CLABSI due to the bacteria thriving in the high glucose solution. And so using sterile technique when handling the TPN bags, the tubing, central line dressings, this is going to be the most effective way in preventing infection before it starts. Okay. Letter B is incorrect. Verifying the prescription detail match the label on the TPN solution. This is a good intervention. However, this is a safety check regarding TPN formulation is administered, but it does not prevent infection. Letter C, administer preventive antibiotic therapy as a precaution. Well, prophylactic antibiotics are not standard practice for TPN patients because they can promote antibiotic resistance. Now, the last option here, check the patient's vital signs every 4 hours. We know that vital signs monitoring can detect infection, but it does not prevent it. Well, by the time fever or maybe sepsis is detected, the infection has already developed. And so, for you to answer this question correctly, you have to take on to the clues, right? Most effective in reducing infection. This simply means you have to focus on prevention, not detection. So you're going to look for the words sterile technique. These are key to infection control in invasive procedure management. All right, let's have number 7. A patient receiving TPN expresses concern stating, I don't want lipid infusions because they might cause weight gain. What is the nurse's best initial response? Options. A. Explain that lipid infusions provide essential fatty acids necessary for health. B. Clarify that lipid infusions serve as a replacement for dietary fat intake. C. Request that the healthcare provider discuss lipid therapy with the patient. And D. Explore the patient's feelings about how their condition affects self-image. The answer is letter D. Now, this question is focusing on therapeutic communication rather than just providing factual information. And the patient's statement suggests an emotional concern. There's fear of weight gain. And so your best initial response is to acknowledge and explore their feelings before giving them the education. And so letter D, this is going to build rapport and also help the patient feel heard, which is very key before providing an education. Because if they don't feel that that they're welcome, if they don't feel that support, then the education would be just not gonna be effective. Letter A, well, explaining is correct, right? Especially scientifically, right? This is necessary, but it does not address the patient's emotional distress. Letter B is also incorrect. Clarifying diet, dairy fat replacement. This is factual information, but this actually misses the opportunity for you to validate the patient's concerns. Letter C is also incorrect. This is requesting provider discussion. This is something that can delay the nurse's opportunity to establish trust and also to address the issue directly. And so again, go back into the question stem. It says here, what is the best initial response? This is your signal that you need to start with patient-centered communication before providing education or referring them to the provider. You need to look for the emotional concerns in the questions, and this often indicate the need for therapeutic communication techniques. You need to use active listening, validation, and open-ended questions. All right. So At this point, you need to eliminate those choices that jump straight to factual information sharing when the patient is currently expressing emotions. And if the patient is expressing worry, or if they have fear, or let's say frustration, the correct response would be to use therapeutic communication rather than education or involvement by the medical provider. Number 8, a nurse observes redness, warmth, and purulent drainage at the insertion site of a central line in a patient receiving TPN. What is the most urgent action the nurse should take? Options: A, notify the healthcare provider immediately. B, contact the pharmacy to obtain a fresh TPN solution. C, replace the IV tubing with a new set. D, reduce the infusion rate of the TPN. The answer here is letter A, notify the healthcare provider immediately, because the redness, the warmth, purulent drainage are classic signs of central line infection, CLABSI. This can rapidly lead to septicemia. It can lead to sepsis within just a few hours, even minutes, if you're not addressing this immediately. Again, septicemia is a life-threatening condition. This is a high priority situation that you need to promptly address by notifying the healthcare provider right away. So to possibly obtain an order for cultures, maybe antibiotic therapy, and possibly the removal of the central line. Letter B is incorrect. Letter B, contact the pharmacy to obtain a fresh TPN solution. Well, this really not gonna address the active infection that is going on, so eliminate that. Letter C, replace the IV tubing with a new set. This is part of good infection prevention practice, but it does not treat an active infection. We are supposed to notify the doctor this time. Option D, reduce the infusion rate. It does not address the infection as well. Okay, so again, we're talking about central line infection. We are dealing with a TPN. This can escalate quickly. And so notification to the medical provider immediately is our priority. Okay, the keywords in our question stem are redness, warmth, purulent, drainage. These all suggest infection. So you should think about sepsis risk. All right. And the phrase saying urgent action means you need to find the action that prevents further harm or deterioration. Number 9, the nurse is preparing an evening dose of regular insulin for a patient receiving TPN based on a sliding scale protocol. Which approach is most appropriate for determining the correct insulin dosage? Options: A, adjust the dose based on the total volume of TPN received since the last insulin administration. B, use the fasting blood glucose level recorded earlier in the day to determine the dosage. C, modify the insulin dose based on the patient's food intake during dinner and snacks. D, determine the insulin amount based on the blood glucose reading obtained just before administration. The correct answer here is letter D. Well, the sliding scale insulin is always based on the patient's most recent blood glucose level. And since the TPN can deliver a continuous, or it delivers continuous blood or continuous glucose supply, the insulin must be adjusted in real time, not based on past readings. And it is best practice that the blood glucose reading should be obtained just immediately before the dose of the insulin is supposed to be given. Okay? Not even within an hour. An hour could possibly be inaccurate already. All right? So that's the best practice, to always do the blood sugar reading or finger stick blood glucose just right before the dose of insulin is due. Okay? What about letter A? Why is this incorrect? Well, because glucose fluctuations depend on how the body is metabolizing glucose. So not just how much TPN was infused. B is also incorrect because using fasting blood glucose from the day does not reflect the patient's current glucose level, which can actually change significantly. Letter C is also incorrect when you're modifying based on food intake. This is irrelevant because the TPN patient do not eat regular meals. And so their glucose control depends on TPN composition and insulin administration. And so when you choose the letter D here, you are actually ensuring that the insulin is appropriately dosed based on real-time glucose needs. So this is going to reduce the risk of either hypoglycemia or hyperglycemia. And so I'm just going to show you right here an example of a regular insulin sliding scale. And it's actually to be done every 6 hours. And this is really just a quick example here. And the guidelines included checking blood glucose levels every 6 hours, while on TPN, administer regular insulin subcutaneously per the scale below. It states in number 3, if blood glucose is consistent above 250 milligrams per DL, notify the medical provider. Number 4, if blood glucose falls below 70, hold the insulin and provide dextrose as needed. And 5, if TPN is discontinued, monitor blood glucose closely to prevent hypoglycemia. And so, for example, you're working as the nurse on this shift, and it's 12 noon. And that is the due schedule for the regular insulin, right? And so you're going to be checking the blood sugar right before the dose. And so, for example, if you got the patient's blood glucose and with a value of 210 milligrams per deciliter, so you're going to base your insulin dose to this range right here. And so it means that possibly your patient is going to get 4 units of their regular insulin for the 12 noon. Now, probably around 6 p.m. or 1800 hours, you need to check the blood sugar again. And maybe the blood sugar went up to 230. And so around that time, you're going to have to administer 6 units of the regular insulin as ordered. Okay, so this is actually how a sliding scale works. Okay, so this is a standardized kind of a procedure when you are dealing with a patient that is on a TPN. So I hope this clarifies what a sliding scale is. Number 10, a nurse is assisting in the removal of a central venous catheter. Which instruction should the nurse provide to the client? Options: A, inhale deeply and hold it. B, roll onto the left side. C, shift onto the right side. D, breathe out slowly and steadily. The answer here is letter A. And so when a central venous catheter is removed, there is a risk of air embolism. Again, this is a life-threatening case. Now, the correct technique to prevent this this procedure, you're actually instructing the client this time. And so the correct technique is to instruct the patient to perform the Valsalva's maneuver. So this involves taking a deep breath and holding it while the catheter is being removed. And the reason why this is effective, it's because the maneuver increases the intrathoracic pressure, which temporarily collapses the central veins. It will prevent air from entering. And so this is going to reduce the suction effect of negative pressure inside the veins. I want you to remember that. Now, why is letter B and C incorrect? Roll onto the left side and C, shift onto the right side. Well, let's tackle first onto letter B, roll onto the left side. This is actually a maneuver that is used after an air embolism is suspected. And the reason for that, this is to trap the air in the right atrium. But this is not done in the catheter removal, okay? This is not applicable in this case scenario. What about letter C, shift onto the right side? Well, there's no physiological basis for rolling the patient into the right side during the catheter removal. It does not help prevent or manage embolism either. Okay. What about letter D? Breathe out slowly and steadily. Well, when you instruct the patient to do this, this does not create enough intrathoracic pressure to prevent air entry. So this is going to be ineffective as well. So I want you to realize this when you are going to be asked about this kind of test question. It said here, should provide, should the nurse, what instructions should the nurse provide to the client? So this signals you that you are to give an instruction before or during catheter removal. Okay, and so you need to also look for the keywords related to the complications. Central venous catheter suggests risks like air embolism. Okay, now another tip for you, if there is going to be a suspicion of air embolism, let's say dyspnea or maybe cyanosis or hypotension, you immediately place the patient in a left lateral Trendelenburg position and administer high flow oxygen while notifying the provider. But in this case, this is more of like a preventive measure to prevent the air coming into the arterial circulation, or the venous circulation rather. And so the best instruction is to do letter A. Number 11. The nurse administers a fat emulsion as part of the total parenteral nutrition based on the understanding that this type of solution, A, supplies additional carbohydrates, B, provides necessary fatty acids, C, supports maintenance of normal weight, D, enhances glucose metabolism. The answer is letter B. We're talking about lipid emulsions or fat emulsion. Okay, so this is intended to provide the essential fatty acids and extra calories, since the body cannot synthesize the essential fatty acids. So they must be obtained through external sources. Now, letter B is, that is a correct answer. And so letter A is incorrect, supplies additional carbohydrates. Again, look back into what we talked earlier. Fat emulsions are made of triglycerides from soybean or safflower oil, not carbohydrates. Letter C is also incorrect, supports maintenance of normal weight. We know that fats contribute to caloric intake, but weight maintenance depends on the total caloric balance, not just lipid infusions. Letter D is also incorrect, enhanced glucose metabolism. What we know is that fats can provide alternative energy source, but do not directly enhance glucose metabolism. Alrighty, number 12. A client's capillary blood glucose measures 122 milligrams per DL 6 hours after initiating a parenteral nutrition infusion. What is the most appropriate nursing intervention? A, obtain a venous blood specimen for glucose analysis. B, slow down the parenteral nutrition infusion rate. C, recheck the fingerstick glucose level in 4 to 6 hours. D, contact the healthcare provider to modify the infusion rate. Your answer here should be letter C. We know that parenteral nutrition contains high concentrations of dextrose. It can lead to mild hyperglycemia. This is common in the first few hours of infusion. And 122 milligrams per DL is slightly elevated, but not critical. It does not require immediate intervention. And so the best approach in this question is to monitor to see if the glucose stabilizes. Why is letter A incorrect? Because capillary blood glucose testing is sufficient for monitoring in stable patients, whereas a venous specimen is only needed for suspected critical hyperglycemia. And so we need to have that laboratory confirmation, but not in this case. Letter B, slow down the PN infusion rate. Again, nurses cannot adjust infusion rates without a provider's order. And remember that sudden rate changes can cause rebound hypoglycemia, and this is something that you should avoid doing. And we have letter D, contact the healthcare provider to modify the infusion rate. Again, look back into the value, 122 is not critical. There is no immediate danger. No need to contact the healthcare provider at this time. Again, for you to answer this question, you need to pay attention to the phrase, most appropriate nursing intervention. You need to think back. You have to think about logical step before escalating the care. And since glucose naturally can fluctuate, what you need to do next is to monitor first. And that would be letter C. All right. Number 13, a patient recovering from abdominal surgery is receiving PN due to protein calorie malnutrition. What is the best sign that the patient is receiving adequate nutrition? Options: A, fluid intake matches output. B, blood sugar remains below 110 milligrams per DL. C, the surgical wound is healing properly. D, serum albumin level is 3.5 milligrams per DL. The answer here is letter C, of course. We are talking about a patient that had abdominal surgery, recovering from abdominal surgery. And letter C corresponds to that need. That is a reflection. And we know that poor wound healing is a common complication when a patient has malnutrition. And so a proper incision healing indicates that the nutrition is supplying adequate nutrition, whereas glucose monitoring is important for preventing hypoglycemia or maybe hyperglycemia, but it does not directly reflect overall nutritional adequacy. And the fluid balance in letter A, this is necessary, but it does not confirm the effectiveness of the nutrition. And the albumin level of 3.5 in option D is within the lower normal range, but it does not solely reflect proper caloric intake, which is also critical for recovery. And so we don't have any other option but letter C. Number 14. A client who has a prescription for strict NPO is receiving TPN through a subclavian catheter. Which nursing interventions are necessary to promote safety? Select all that apply. A, monitor fluid intake and output during each shift. B, change the intravenous tubing every 3 days. C, weigh the patient weekly in the morning. D, measure blood sugar every 6 hours. E, administer the solution using an IV pump at the prescribed rate. This is a select all that apply. Your answers are A, D, and E. So I want you to recall that flat emotions, okay? So this is a patient who has a prescription of strict NPO with a TPN. So why is letter A correct? Monitor fluid intake and output during each shift. Remember about the possible complication, hypervolemia. So you want to avoid that from happening. So you will have an idea if your patient really is getting enough nutrition, and also the volume is probably not leading to any issues. That's why you need to do that every 8-hour monitoring in a med-surg setting. Letter D, measure blood sugar every 6 hours. Again, this is a standard action that you should be doing during a TPN therapy. Letter E, administer the solution using an IV pump at the prescribed rate. Yes, this requires proper regulation of the drip. You don't want to increase, or you don't want any chance that the infusion can slow down or maybe getting too fast. You want a consistent rate for the TPN. Now, what about letter B? Change the intravenous tubing every 3 days. This is incorrect. And the reason for that, you need to change the tubing every day. That's the best practice. Every time you need to hang or spike a new bag of TPN, you also need to change the whole tubing setup. You need to change the tubing, also the micron filter every time. That will be considered as 1 unit. Okay, so 3 days of changing the tubing is inappropriate. What about letter C, weigh the patient weekly in the morning? Well, weekly is not best practice. What we are supposed to be doing is daily weight. Again, weighing the patient in such a manner in a daily frequency would definitely help us in detecting any sudden changes in the patient's fluid status. Okay, so that's why you have to do that in daily basis, not weekly. Let's have number 15. A patient receiving a fat emulsion infusion develops signs of intolerance, including a triglyceride level over 300 milligrams per DL, a temperature increase of 3 degrees Fahrenheit to 4 degrees Fahrenheit. There's chills, flushing, headache, nausea, vomiting and sweating, muscle aches, chest and back pain, difficulty breathing, a sensation of pressure over the eyes, and dizziness. Which nursing intervention is most appropriate? A, monitor the serum glucose level. B, turn off the lipid infusion immediately. C, slow the infusion rate. D, ask the patient if they follow a vegan diet. The answer is letter B. Well, let's talk about what's going on here. Sounds quite a handful of manifestations. And so the signs that you're actually seeing here are signs of fat emulsion intolerance, and this is very serious. The appropriate immediate action here is to stop the infusion to prevent complications. Now, don't get me wrong here. We are talking about fat emulsion infusion, not the TPN solution. That is totally different. Remember about TPN solution? These are your amino acids, dextrose, and other additives. But in this scenario, we are talking about fat emulsion, fat lipids, right? And so the patient actually is manifesting an allergic reaction, okay? So the appropriate action here would be to immediately turn off the infusion. And what is really happening here? The fat emulsions actually contain long-chain triglycerides from sources like soybean or safflower. And normally, an enzyme called lipoprotein lipase helps break down these fats in the bloodstream. However, some patients cannot properly metabolize the fat emulsions. And so they're going to end up with hypertriglyceridemia greater than 200 milligrams per DL. And they also have the fever, chills, flushing, headache. And so these are manifestations similar to an allergic response. They also will manifest nausea, vomiting, sweating. And this is reflecting that there is systemic intolerance. And the chest pain, the back pain, the dyspnea, this is possibly happening due to a fat emboli or possibly an inflammatory response. Now, if you do not stop the lipid infusion, the patient's symptoms could worsen. It can lead to fat overload syndrome, which is a dangerous condition wherein there is going to be excess fat buildup in the blood, which can cause organ dysfunction. And we're talking about multiple organs here, the liver, the lungs, the immune system. And also the high triglycerides. Take a look into the triglyceride levels. 200 milligrams, over 200 milligrams per DL. This can also trigger an inflammation of the pancreas. And so the bottom line here is that the safest thing to do is to turn off the lipid infusion immediately to stop the reaction from getting worse. Now, why is letter A incorrect? We know that glucose monitoring is important for patients receiving TPN, but this patient's issue isn't about high blood sugar. We are dealing with fat intolerance. And lipid emulsions don't significantly affect glucose levels, and so checking the blood sugar won't address the immediate issue. Letter C is also incorrect. Slowing down the rate of the lipid infusion can maybe help if the patient had mild discomfort, maybe mild nausea or slight fever, but this patient is showing systemic intolerance. So the reaction is already severe, so you need to stop the infusion right away. Letter D, ask the patient if they follow a vegan diet. Well, a patient's dietary history including whether they consume animals or fats, is not relevant in this acute situation. Your priority this time is to stop the infusion immediately. You don't gather background dietary information this time. So, for you to answer this question correctly, you need to pay attention to the clues, the symptoms, the fever, chills, nausea, vomiting, the high triglycerides, chest pain. That's a huge one right there. Chest pain actually is a red flag. It could mean that there is now insufficiency of blood supply to the coronary arteries, or maybe a sign of fat embolization, dyspnea as well. And so, again, this points out to the fat emulsion intolerance or maybe fat embolism. So it simply means that the infusion should be stopped immediately, right? So whenever a question describes a systemic reaction to an infusion, your safest answer is usually to stop the infusion first. Now, once you stop the infusion, the following steps should be to notify the healthcare provider for further instructions. You got to monitor for the vital signs for the detection of worsening reaction. Need to check the recent lab results, especially the triglycerides and liver function tests, and also to assess the patient's oxygenation if they have respiratory symptoms. And so, your final strategy in answering this question is to remember, especially if the patient is having a severe reaction to a fat emulsion, stop it immediately. And if the symptoms reflects fever, nausea, vomiting, flushing, high triglycerides, dyspnea, these are systemic symptoms of the intolerance. So you don't need to waste time with unnecessary interventions like checking glucose or dietary history. Eliminate those right away. And think about safety first question, okay? Always think about which intervention will prevent harm the fastest. And so that's the end of our Q&A today. I hope this Q&A session is beneficial to your NCLEX review, and don't forget to like and share this video. And if you have any questions, don't hesitate to post your comments below, and we'll try our best to answer promptly. I'll see you next time.